Okay, so this presentation is going to be over some of the alterations in oxygenation as it pertains to the multi-system disorder class. The chapters that we'll be covering will be Chapter 27, which deals with assessment of the respiratory system. In Chapter 28, there's a part of that chapter that talks about the different oxygen delivery systems that would be a good idea for review, not only for testing purposes, but also for our critical care skills, as well as preparing you to go into the critical care areas from a clinical standpoint. Chapter 30 deals with some of the non-infectious processes of the lower respiratory system. So this will be looking at things like cystic fibrosis, pulmonary hypertension. There's also some good information on chest tubes in there, which again is going to go back to your critical care skills lab that we're going to have, as well as preparation to go into those critical care areas, as well as when we talk about things like pneumothorax. Understanding how chest tubes work is going to be important there. Chapter 31 looks at some of your infectious respiratory problems. These are things like your flu, your severe acute respiratory syndromes or SARS, pneumonia, and TB. And then finally, Chapter 32 will look at those patients who have critical illness type things dealing with the respiratory system. So these are things like pulmonary embolism or PE, acute respiratory failure, acute respiratory distress syndrome or ARDS is something that we will talk about, as well as attention pneumothorax. And this chapter, Chapter 32, also will look at ventilator management, which again is something you need to know from the standpoint of how you're going to take care of these patients who are critically ill, but you're also going to need this knowledge when you go into the critical care setting for clinical. So one of the first things you need to understand is how the respiratory system works as far as the concept of gas exchange and tissue perfusion and what occurs. By this point, you should have a pretty good understanding. We know that the lungs will take in our oxygen. The heart will pump the blood. It will pick up the oxygen from there and then send it out to the rest of the system. And so if the lungs are not functioning properly or are not doing their job to oxygenate that blood when it comes through them, it's really hard to deliver that to the rest of the body and to keep those tissues perfused properly. So I've got in here an IGI. There are some pages to kind of look over, page 508, 512, as well as 616 and 617. The first little part of that chapter really helps identify how that concept works with gas exchange and tissue perfusion as it relates to lung function. Okay, so now that we've talked about that basic concept of gas exchange, we're going to talk a little bit about the assessment of the lungs and the thorax. One thing that's not on here that is important is to make sure that you always get a good history from your patient, get that subjective data and all that kind of good stuff. One of the first things that we do is we inspect the thorax, or we look at the chest itself. When we're doing that, we're looking for chest expansion. Does it rise and fall equally on both sides? You always want to compare one side to the other. If you have somebody breathing and one side does not expand and the other one does, it's a good concept there that maybe they've got something like a pneumothorax or a hemothorax or something going on that's preventing that lung or that chest wall from expanding on the one side. We assess, we work from the top and we move downward toward the base from side to side. You should remember that from first semester in your assessment class. We always look at the rate, the rhythm, and the depth of the inspiration as well, like I said earlier, that chest symmetry in the movement and how it works. We do want to listen anterior and posterior as well as laterally when we're assessing our breath sounds. Look at the distance between the ribs. You're going to also in those intercostal spaces, it's important to assess those because if a patient is having difficulty breathing, you may see some retractions in those areas. They can be between the ribs, they can be up underneath the clavicle, or they can be like right below the rib cage. You'll see them kind of sucking in, especially in children. That's something that we always like to assess is those intercostal spaces for retractions. And then you also are going to palpate to assess for respiratory movement by placing your hands. Do you feel the chest open and close at the same, depth and rate? Something that you probably are not going to do much of, but you can also do percussion, which is, I did not include on here, but that is listed in your book. And then another thing is you want to feel the chest, especially if you, like I said, suspect somebody has something like a pneumothorax. They may have had air leak into the surrounding tissues, and so they may have something called crepitus, which when you feel the chest wall, what happens is air gets trapped in the subcutaneous tissue, and it almost feels like Rice Krispies when you're feeling across the chest wall. So you want to check for that as well. Okay, some other assessment techniques when looking at your lungs and the thorax area is something called diaphragmatic excursion, and this is actually doing that percussion that I mentioned on the previous slide. And this is just by taking your finger, you kind of lay it, it's usually the middle finger, you lay it down on the chest and you lightly tap with the middle finger on the other hand, and you're feeling for differences in dullness and resonance. And it's just something you have to kind of practice. You'll develop the feel for it after you do it a while. So with diaphragmatic excursion, you have the patient exhale or get all the air out of their lungs and have them hold their breath while you're performing this percussion. And what you're listening for is that high resonance down to dullness. And you mark that spot, and then you have them take a big deep breath in and have them hold it, and you do the same thing. You percuss down until you feel that dullness occur. And then at this point, you mark it. If it's less than 3 to 5 centimeters, it may indicate that the patient either has pneumonia or a pneumothorax going on within the chest. And then that would be something that you would confirm with an x-ray. And then just real quick, your different lung sounds, you have bronchial, bronchiovesicular, and vesicular lung sounds. And the things that we typically listen for are adventitious breath sounds like our crackles, which may indicate atelectasis, bronchitis, or pneumonia. They may have wheezing, which is an inflammatory process from edema or even bronchospasm. They may have rhonchi from sputum production or obstruction or even a tumor. One thing, if you do hear rhonchi in somebody, I would always tell them to cough, because a lot of times, sometimes they may just have sputum that they need to clear out, and once they cough, you can clear that. And then also a pleural friction rub, which may be indicative of pleurisy, pneumonia, or TB. Okay, now that we've discussed the assessment piece from chapter 27, we're going to look at some of the infectious processes that can occur with our respiratory system. Influenza, this is looking at seasonal flu, like what we would expect this time of year. We're really hitting what we would call the peak season of flu, although this year it seems like flu season started very early in this area, and I know it's getting rather rampant across the country. We're seeing a lot of people already being diagnosed with the flu. Flu is a highly contagious viral infection. It usually affects the respiratory system. You can have strain B, which will still have respiratory symptoms, but also nausea, vomiting, and diarrhea can also accompany this. You'll see clinical manifestations, a severe headache, you'll have a lot of muscle aches, the patient will usually run fever, and it's usually a fairly high-grade fever. They can have chills, they'll be tired, they'll be weak, they won't want to eat. I think most of at some point in our life we've been diagnosed with the flu, so we kind of know what those clinical manifestations look like. Vaccination is advisable. The best prevention for flu is to stop it from occurring, and the way we do this is through vaccination, whether that vaccination be through an IM injection that is given or in a flu mist, which is done through the nasal passages. Keep in mind though, with flu mist, you don't want anybody who may be immunocompromised taking the flu mist, because it is actually a live virus as opposed to the one that's given IM, which is a dead virus, shall we say. So you can actually catch the flu from vaccination in the IM form, but you could actually make somebody sick with the live virus through the nasal spray. The best thing we can do is educate our patients that if they present with these kinds of signs and symptoms that you would expect with the flu, that they come to the doctor as soon as possible. Don't wait it out at home. because the antiviral medications that have to be given need to be started no more than 48 hours after onset of symptoms, or that's the recommendation, is that they're most effective between 24 to 48. I know some will go 72 hours out, but most effective in that early window of diagnosis. The other thing is it's not like an antibiotic where it will kill the virus, but what it will do, it will slow down the replication process so that the virus is shorter lived within the system or within the body. A lot of what we will do for patients with flu is it's supportive therapy. So we give them, things to control the fever, like we'll do ibuprofen or Tylenol to help with fevers and those body muscle aches and the headache. We'll encourage rest. We'll encourage fluids. If they are coughing up stuff, we'll recommend things like guaifenesin that are an expectorant to get that stuff loosened and out of the system. So a lot of it is supportive. I have written on here, when studying, focus in on those health promotions and maintenance and focus in on the patient-centered care, which in your book, it's on page 597, where it talks about the interprofessional collaborative care dealing with the patient who has influenza. Okay, so we've looked at seasonal flu, which is, what we typically see around here, but there is another thing called pandemic flu, and these occur, how do I say this? These are viruses that usually have mutated themselves. They start out in other species, like pigs, for instance. We all remember the H1N1, which was a swine flu. A few years ago, we had H5N1, which was an avian flu. So they start out in other species, and then they mutate themselves, and then they can affect humans. Now, the problem with this is because they're not a virus that is typically what we see in a human being when they cross over, the human body has not developed any immunity to that. So these people who usually get sick with these pandemic type flus usually get very, very sick, and it can cause a lot of devastation, a lot of death. And it can kill thousands, if not millions, of people when these occur. So typically, when we're dealing with these, they are very. When this occurs, it will be under strict isolation. The patients will be placed. Usually, it's airborne isolation. So. They're going to be treated almost like a TB patient. They're going to be put in a negative pressure type room. You're going to have to have special PPE when you go into the room. They're going to contain them. If they're I remember several years ago when I believe it was the avian flu, they actually had a plane come in from China where somebody had tested positive. They took all the patients and actually put them in quarantine, or all the patients, all the people who were on the plane, they actually took them and put them in quarantine for a while, just to make sure nobody else was infected on the plane before they let them go out into the general population. So very, very strict isolation precautions with these patients. We do still use the antiviral drugs that we would typically see to treat the seasonal flu, like the Valenzas or the Tamiflu. Again, we want them to take it 24 to 48 hours on the onset of the symptoms. I know that H5N1, or that avian flu, does have a vaccine for it that they have. They don't routinely just give it to people. They stockpile it. Therefore, if they have an outbreak, they then go in and vaccinate that region where they're seeing the outbreak of the flu. And again, for studying purposes, I would also spend some time looking at that health promotion, maintenance, and that collaborative care, which is on page 598, and also I think there's the health promotion is on page 597, so I would kind of look that over. Okay, so now we've talked about flu, and one of the shall we say, risks of developing the flu is you can also transition this into pneumonia. It doesn't always have to be precipitated by the flu. Pneumonia can be caused from anything that's inhaled that can cause an inflammatory response, whether that be bacteria or it could be an inhalant of some kind, or in the case of having the flu, it can weaken the immune system down where it just sets the body up for the development of pneumonia. But basically what happens is you get an excess amount of fluid that in the lungs that results from this inflammatory process. Like I said, it can be triggered from an infectious process. It can be triggered from inhaling some kind of irritant that starts it. You can develop something called an empyema, which is a pus formation in the pleural cavity that may need to be dealt with. This could be affecting like a lobar pneumonia or lobular pneumonia, you heard that term, where it's affecting part of a lobe, or it can be kind of scattered throughout the bronchi with like a bronchopneumonia. So some different types of pneumonia that can occur. It can be community acquired, or it could also be acquired while in the hospital. Especially we think about our ventilator-associated pneumonias or our VAPs. You'll hear them talk about that when you work in the hospital. I did write on here that there is a really good concept mapped on page 602 that deals with community-acquired pneumonia. Probably be a good thing to kind of look that over. And then again, I would really kind of focus in on the health promotion and management and maintenance. We do have available pneumonia vaccines for people who are in a high-risk group for development of pneumonias. We typically, give those to the older population, especially if they have a history of asthma, COPD, things like that. So prevention is a big thing in those people. So just something to think about. And most of this is can be found on our pages 599 through 605. So we're going to talk a little bit about ventilator-associated pneumonias, or this VAP. And it says E, page 631, but actually the majority of this is on page 600. 631 deals with the ventilator itself, and so there is a little more in there on care of the patient on a ventilator. But this basically occurs because the patient has an endotracheal tube that goes down into the lungs. And it's kind of, if you think about, we talk about CAUTIs with catheter-associated urinary tract infections, the same thing is true when we're looking at ventilator-associated. We have a tube that's going down. It's a perfect transport system, shall we say, for like microorganisms to travel down and then set up in the lungs. So the best thing that we can do for our patients who are on a ventilator, and usually with ventilator-associated pneumonia, you're usually, it's about 48 to 72 hours after the patient has been intubated that you would probably start to see signs and symptoms of the pneumonia. But we know one of the best things that we can do is decrease the incidence by prevention. And so one of the things we talk about is ventilator bundles. And this one comes out of your book. You probably see when you work in healthcare facilities, each facility has its own ventilator bundle, but they're going to be very much the same or very, very similar. Good hand hygiene makes sense. Oral care per agency policy. Most places recommend that you do oral care every 2 hours on your patients, and you'll see when you get to the critical care settings that they actually have little trays with all this set up. So it's a reminder to you that every 2 hours you need to provide your oral care for your patients who are on a ventilator. You want to keep the head of the bed elevated to at least 30 degrees. Do prophylaxis for ulcers as well. We don't want any like reflux going on during this point. We're going to prevent aspiration, and also good pulmonary hygiene, things like chest physiotherapy, pulmonary drainage, and also turning and positioning our patients to make sure that we're, keeping those lung fields not just being compressed. We don't think sometimes, but, if the patient's laying on one side consistently, that one side that's down is not getting ventilated as well as the side that is up. So it's important that we turn and reposition the patients frequently. Okay, so when we're assessing for pneumonia, what kind of things do we look for? Of course, taking a good history from the patient. They may have started out with some kind of respiratory issue, whether it be, a cold or a flu. Usually that's what leads the patient to the development of pneumonia. So some of the laboratory things that we're going to do, we're going to get a CBC and look at, your white blood cell count. You're also going to look at your electrolytes as well as your creatinine and BUN. And this is also looking at potential for therapy. You want to know what your kidney functions are, because chances are these patients are going to be on some kind of antibiotic therapy. They may draw ABGs if the patient is having, especially if they're having any respiratory distress, to see where they are as far as oxygenation is concerned. We will try to get a sputum sample so that we can do a culture and sensitivity to determine what organism is actually causing the pneumonia, and also what kind of antibiotics is that particular organism sensitive to. Chest x-ray pretty much always is going to occur when you suspect pneumonia, just to make sure that that is what you're seeing on the film. We'll watch their pulse oximetry, again, making sure that they're oxygenating well. People can have pneumonia and still have a fairly decent pulse ox reading. They may do transtracheal aspiration, and that's just a technique that's used to collect the culture if they need to. And for some patients, they will go ahead and do a bronchoscopy to actually go down and get a sample, like a sputum specimen and stuff like that, from the actual patient. And then I've written on here, what would you expect to see in the physical assessment? So think about that. When we talked about those little assessment pieces on those first few slides, in your mind, get a picture of what you would expect the patient with pneumonia to look like. One of the tricky things is sometimes people can have walking pneumonia, and they've got the cough, they may be a little short of breath, but one of the biggest things they complain about is just being incredibly fatigued. So pneumonia does not always have to look like the patient is panting, having a hard time catching their breath. They may be mildly short of breath with exertion. So, but just kind of think about what assessment findings would you expect to see in these patients. And then we will look at your community-based or community-acquired, and these are more like the type that you're going to see, out and about, that they got them from, some kind of healthcare setting, or I should say outside of the healthcare setting, not within the healthcare setting. But these would be the people like showing up to the doctor's offices and things like that, or presenting to the ERs. So how do you manage them? You want to think about in-home settings, how are they going to sleep? Maybe difficult for them to sleep lying down. They might want to be propped up. Getting to the bathroom can be difficult for them. Teaching self-management, so things medication-wise, the needing to take all their antibiotics and finish them. Keep in mind that people can have pneumonia and not be hospitalized. We don't hospitalize very many people at all, now that I think about it, who have pneumonia, unless they are having some respiratory difficulty that requires like the administration of oxygen and stuff like that. And a lot of people are managed in the home. So, you do want to caution people. I think people like with who are immunocompromised, patients who have COPD, patients who have asthma. If they know somebody has got a cold, some kind of respiratory infection or the flu, not a good time to go over and visit. Prevention goes a long way in these people, because their friend might have the cold, but they may wind up with pneumonia because of them being compromised. And then another thing is smoking cessation. Again, we know that smoking damages lung tissue and just sets the patient up for even more potential of development of pneumonia. And then for those people, immunization is appropriate for those people who are in those high-risk groups. And I would be kind of familiar, how do we treat this? We may use oxygen therapy if need be. May have them do IS to open those airways to get some air movement going through. They may put them on some kind of inhaled steroid. They may do breathing treatments of some kind. Maybe doing antibiotic therapy. So I would just kind of look over pages 604, 605. Has some great information on how to manage the patient. It also talks in chart 31-2 on a focused assessment for the patient recovering from pneumonia, things that you may see. So some good information on those pages. Severe acute respiratory syndrome, or SARS, it talks about it real briefly in your EEG book on page 598 under the MERS is kind of how it's listed there. But if you do look in your ATI book, your med-surg book, in chapter 26, it's titled Respiratory Failure. They do talk about SARS as well as a little more on acute respiratory distress syndrome, or ARDS. These can be a little confusing, but they are different. SARS usually results from the coronavirus family. It's a mutated version of a coronavirus. And a coronavirus is just something that causes the common cold. It actually triggers an inflammatory response within the respiratory tract itself. The biggest thing here is preventing the spread of further infections to other people, and it is spread through droplets, so if sneezing, coughing, talking, that kind of stuff. These people are on very strict isolation, airborne isolation precautions plus eye protection. The eyes, nose, and mouth are the portals of entry, so good hand washing, using the proper PPE with the prevention, with our precautions. Unfortunately, there's no real effective treatment other than supportive therapy. And so if you look in your ATI book on page 154 and 155, it does talk about patient-centered care, and it's talking about maintaining a patent airway, providing suction if need be, if the patient needs to be ventilated. As far as ventilator management, it talks a little bit about that, as well as some nutrition things. So it's a nice little quick bullet pointed section that just kind of talks a lot about the supportive care that these patients may need. These next 5 or 6 slides, we're going to talk about pulmonary tuberculosis, or TB. This is a highly communicable disease caused by the Mycobacterium tuberculosis. If you think back to your micro days, it is transmitted via aerolization. So these patients are on very strict airborne precautions. So these people are placed in a negative pressure room. You do need to wear an N95 mask that's been fitted for you to enter the room. It is interesting to note that several people may be infected with the disease, but they may not actually develop full-blown or active TB. So you can have somebody who has a positive skin test that has never been sick with TB and have it be a little bit of a shock to them. But this is one of the reasons, is because you can actually be infected but not actually develop the disease itself. And then there is also something called secondary TB, and this is where a patient has been previously infected with it, and there is a reactivation of the disease. You can see these in patients who are older, HIV patients, or people who are immunocompromised. I think back to my husband's grandfather. He was a small child. His mother actually died from TB, and he contracted TB as a very small child, he was 4 or 5. And he actually had a reactivation of this later in life as he got older and his immune system started to weaken. So that can occur as a secondary TB. What are some of our risk factors for development of TB? Well, frequent contact with others that are untreated. So if we know that somebody has TB and we have frequent contact with them, it increases your risk. And unfortunately, you may not know that person is potentially a carrier and able to infect you while you're having contact with them. Already mentioned this, people with decreased immunofunction or are immunocompromised, like patients with HIV, chemotherapy patients, other people who may have immunological disorders, crowded living conditions like nursing homes, shelters, mental health facilities. And if you think about the way this disease is spread, that's why this is a risk factor. Because we know people in lower socioeconomic groups are at a higher risk, you look at things like shelters and you may have somebody who's homeless, that is a drug and alcohol abuser. They they living on the streets, they can track this, they go into a shelter and they contaminate or spread this to other people. So these are all risk factors for the development of TB. And then according to the World Health Organization, that's what that WHO stands for, foreign immigrants are also a risk factor when they come into our country because they may already be infected prior to entry. That's why sometimes you may see them when they come in, if they've been sick, they'll kind of quarantine them and check them over before they're allowed out into the population. So clinical manifestations of TB. So what would you expect to see in the patient who actually has TB? Keep in mind, again, you want to do a good history on the patient, especially the social aspect of that, and how they travel, those kinds of things. So what do we look for? Progressive fatigue. The patient will definitely be more tired, and it will just be getting more and more so as time goes on. Lethargy, which makes sense if they're progressively fatigued. They may have nausea. They may start to lose weight. If they're female, they may have irregular menses. They typically will have a low-grade fever, and one of the classic signs that we associate with TB is night sweats. So if the patients, like for instance, they have traveled over to some place like China or even Mexico, and they've come back and they just have not felt well, they're losing weight, they're just progressively getting more and more tired, and they come in and they tell you that I wake up in the middle of the night and my bed is soaked, and they have this cough that they just can't get to go away. That is cause for concern that maybe this patient may be developing TB. So they will have a cough. They usually have mucopurulent sputum, which is typically blood streaked. That's another warning sign that we look for in our patients with TB. So I would definitely be familiar with these. Your book does do a good job in the assessment piece in EEGI on 606 and 607, as well as in ATI Med-Surg. It's chapter 23 on page 135. It gives you clinical manifestations of TB. So how do we diagnose TB, or what are we looking for? I already told you you're going to do a history. You're going to do that physical assessment. What kind of clinical manifestations is the patient actually complaining of, or what are you seeing in your assessment findings? Diagnostically, we're going to look for those manifestations. Probably the most common one you will see is a sputum culture, and usually they will do this for acid-fast bacillus, or the Mycobacterium tuberculosis. Usually the hospital will want 3 different sputums collected over 3 days. All of them need to come back clear before they will actually clear the patient to take them out of isolation. Again, that's going to depend on your hospital policy, but that's pretty standard across the board. They may do this NAA, which is a nucleic acid amplification type test, which is used from a purified protein derivative from the PPD. It can give results in about 2 hours. Your book talks about some other different tests that can be used both in your IGI as well as in ATI. The one that most people are probably familiar with is the Mantox test, or this PPD. That's when you guys get every year, where they take and inject a little bit of this intradermally in your forearm. Anything within duration greater than 10 millimeters or greater means that you've been positive for exposure. Does not mean that you actually have TB. It just means that you have been exposed. Now keep in mind, the induration is actually the raised area, not the redness. Sometimes you'll see redness around a raised area. You don't measure that redness area, you measure the area that's actually raised. That's that induration piece. One other thing to note is in people who have reduced immunity. So we're looking at patients again who have some kind of autoimmune or an immune disorder, like HIV, where they tend to be immunocompromised. They may not actually produce a reaction to a TB skin test because their body does not have the ability to react to it. And this is something called anergy, where they may test negative when they are, when they're actually positive, because of the body's lack of immune system to create the response that it would normally create if the patient had an active working immune system. This is a little picture of an actual TB skin test. You can see that the patient does have, a reddened area, but more importantly, we're looking, like I said, at that raised area. Told you it does not mean that the patient actually has active TB, but that the patient has been exposed at some point. 10 millimeters is usually the indication for a positive test, but in those patients who are immunocompromised, like I said, they can have that energy response where the immune system is not working. They may not react at all. Or if we have a patient who we know has a known diagnosed immunocompromised problem, if they were to create an induration of greater than 5 millimeters, we would consider that a positive test for that particular patient. Okay, so how do we treat them once we know that they now have diagnosed TB? Well, we're going to do all that supportive care that we would do for other patients with respiratory issues to help facilitate respiration and oxygenation. But you're also needing to be familiar with some of the TB medications that are used. They're typically used in combination. And I will tell you that these are some of the ones that you're most likely to see, especially on your exam and on your NCLEX. Your book does a really great job on page 608 in chart 31.3, where it actually gives you these medications that you will see given to the patients and the nursing implications. I would tell you to know these. NCLEX loves to ask about rifampin and the fact that it turns the patient's urine orange. It's just one of those things that they want you to know. I think of all the things about a medication. Yeah, your patient probably needs to know that, but I would be more worried about some of the other complications that may be associated with that, like liver damage. But that is just something that they like for you to know. They may also use fluoroquinolones and aminoglycosides, which are types of antibiotics. There is some good information on your medications as well in your ATI book on page 137. And don't forget about nutrition. We want to make sure they have proper nutrition to heal those cells. So things that are high in protein, iron, vitamin B, and vitamin C to help with that. And the patients are considered no longer infectious once they have those 3 consecutive sputum cultures that come back negative. At that point, they are considered no longer infectious to the rest of the population, and they will be removed from isolation at that point. Lastly, we're going to talk about community-based care. Because this is such a highly infectious disease, and we've had epidemics of it in the past. I don't think we see that as much anymore because of the screening. But back in the day when I talked about my husband's grandfather and his family, there were several members of his family that died from TB. And so we don't want to see those kinds of things happen again. So being able to teach the community and teach our patients about the importance of making sure they adhere to the therapeutic regimens, especially the medication regimens. People don't like to take medications for very long. I think about how many people get an antibiotic that they're supposed to take for 7 to 10 days, and they wind up taking it for 4 because then they feel better, and then they come off of it and they just don't want to deal with taking, that big pill for another 3 days. But with these patients, a lot of times they will be on medications for months. And so following up is very important for them to be under some kind of medical supervision. If the patient is not adhering to the prescribed regimen, they may need to be placed in some kind of nursing facility to ensure that they are doing this for the safety of the public, but also for their own well-being. You definitely want to teach them about the side effects and, like I said, that importance to adhering to the therapy. They may start out doing well, and then they stop their therapy, and then they wind up being sick again and also infecting other people. So letting them know and understand the importance of that. And then also something on here is that the book talks about is referral to like Alcoholics Anonymous, because keep in mind the population that is at risk. We will see that in some of our drug abusers and our alcohol abusers. So whether it's to AA, other support groups for drug intervention would be a good thing for these particular patients. Okay, so on these next couple of slides, I just got two on here, and we're going to talk a little bit about inhalation anthrax. And I know this is a topic that Angela also talks about in her class 2243. It is caused by a gram-positive organism known as Bacillus anthracis. It is naturally occurring in the ground. It's usually in soil. So typically, this is an organism that affects like cattle and livestock and things like that. But it can occur, or naturally occurring cases are normally found on the skin, and they are very treatable with just the use of antibiotics. However, inhalation anthrax, which we're going to focus on for this class, can account for about 5% of the classes, or for the cases. It is not spread by person-to-person contact. So if somebody has inhalation anthrax, they cannot spread it by breathing on you or coughing on you. So it's not spread by droplet or aerosol or anything like that. You have to actually come in contact with the anthrax itself and actually inhale it in. It can be an occupational hazard for people like veterinarians, farmers, and other people who may come in contact with this substance. Excuse me, I'm going to cough. But if you think about it, because it is found in the ground, typically, that's why farmers are at risk. If we're dealing with livestock and cattle, that's where veterinarians are particularly at risk for this, coming in contact with it. Occurrences normally, though, in other people, if they do not have one of these jobs or have a reason for being exposed, is considered an intentional act of bioterrorism, because anthrax is one of those things that is being used as a bioterrorism weapon. Infections in the lungs, which that's where they usually occur when they're inhaled, are usually about 100% fatal if left untreated. Okay, so continuing on with inhalation anthrax, I did get a cough drop, so hopefully I don't cough all over you guys on this slide. It does have two different stages once it's inhaled. And actually, if you look in your book on page 582, it does a really good job with the pathophysiology of explaining how this enters in, forms spores, infects the white blood cells, spreads throughout the body, can even infect, like the brain can develop meningitis from this, and eventually develop sepsis. So it does a good job kind of spelling out how that process happens. But it does occur in these two phases, this prodromal phase and the fulminant stage. So in the prodromal phase, this is the early phase. It can actually be hard to distinguish whether this is inhalation anthrax or if this is more like the flu or pneumonia developing. But in this phase, symptoms are usually low-grade fever. They can be fatigued. They may have some mild chest pain and maybe a dry, kind of harsh cough. There's no indications, however, that there's any kind of upper respiratory type signs and symptoms. So, usually with the flu or even with development pneumonia, you usually see the person have like the complaint of a sore throat or a runny nose or rhinitis. You don't see that with inhalation anthrax. And also in this prodromal phase, if you did a chest x-ray, you can see widening of the mediastinal area on a chest x-ray. So those are the kind of things they look for in that prodromal phase. This usually starts and the patient actually starts to feel better and the symptoms improve in about 2 to 4 days. If the diagnosis of inhalation anthrax can be made at this point, the patient has a good chance of survival. However, if it proceeds on to this fulminant stage, which this begins after the patient, starts feeling a little bit better than they have been, they suddenly have this onset of severe illness. And what you see here is usually things like respiratory distress. They may have some hematemesis, or where they vomit up blood. They will become very short of breath or become dyspneic. They may be diaphoretic. They will develop a stridor. They can have pain in their chest, and they can become cyanotic. And they also develop like a high fever. They can hemorrhage. They can develop pleural effusions. They can become hypotensive and go into septic shock. And then they can also develop mediastinitis, which is, or mediastinitis, is what I meant to say, which is inflammation of that mediastinal area. So this is the point we don't want them to get to. This is where they can develop like that hemorrhagic meningitis. They go into septic shock, and once they enter that shock phase, it's always difficult to bring somebody back. But death, if they enter into this fulminant stage, can occur within 24 to 36 hours, even if they get the antibiotics started. And some of the antibiotics used to treat this are listed here, things like ciprofloxacin, doxycycline, amoxicillin, rifampin, clindamycin, and vancomycin. And because when we're dealing with this in situations that it's not a normal population, so if this were to occur like to a businessman who by bioterrorism got exposed to this, those things have been engineered. The bacteria itself has been altered and engineered to be more, more potent and more resistant to current antibiotics. So they tend to use a combination instead of just one to treat this, to give the patient a better chance. And also because this will develop toxins, endotoxin. They have developed this anti-toxin monoclonal antibody, which is approved to be used once the symptoms begin and the diagnosis is made. And this has shown some promise, but the drug itself, which a lot of monoclonal antibodies can have some pretty significant side effects because of the way it works on the immune system. So it's better, in all likelihood, it's better to give it. And if they have severe side effects, you'll deal with those. Because if you don't do it, you know for sure they're going to not survive if you don't treat these patients. So in your book, there is a box of key features for inhalation anthrax that goes over that prodromal stage, those early versus late signs and symptoms, which is something I would tell you to kind of take a look at, because I would expect you to know the difference in those. So cystic fibrosis, again, I've listed the page numbers here for you, so you can have resources to this. This is a genetic disease affecting many organs. It's not just a respiratory problem, although we think of that primarily, but it does affect other organs as well. It is lethal. Life expectancy for someone with cystic fibrosis, born with cystic fibrosis, is about the age of 37. And this is caused from an autosomal recessive disorder. This actually occurs because of an error in the chloride transport system. And what happens is the mucus has very little water, and therefore it becomes very, very thick. When I'm talking mucus, I'm not always talking about mucus in the lungs. I'm talking in other organs as well. And this will eventually plug up the glands, which causes the organ to atrophy and causes the organ then to dysfunction. I will tell you that Khan Academy, and I've put this on my very last slide, or towards the end as additional resources. If you don't watch any of the Khan Academy videos, I strongly recommend that you watch the ones on cystic fibrosis. They do an excellent job at really going into the pathophysiology of this disease, so then it really makes your light bulb come on. I learned about this in school too, but it wasn't until I really watched those videos and saw those drawings that I finally went, oh my goodness, this makes sense to me for the first time. So I would highly recommend that you take some time, they're not horribly long, to just watch the videos on the cystic fibrosis, because it really helps you understand how the medications, the therapies that they do, why they work the way they do. So looking at the clinical manifestations of cystic fibrosis, we have non-pulmonary manifestations and then pulmonary manifestations. Adults are usually smaller, thinner than average due to malnutrition, because they do have a lot of issues with absorption of the bowel in the within the GI tract itself. You will see them with abdominal distension. A lot of them have GERD, rectal prolapse. They have steatorrhea, which because they have a hard time digesting, they'll have a lot of fat in the stool. They typically have a lot of vitamin deficiencies, especially those fat-soluble vitamins. So your A, D, E, and K. Very prone to diabetes because of the way it plugs up. Remember how I said that in the first one, because of the chloride transport not working properly, the mucus and the organs are very, very thick. And so it can affect the pancreas. And then osteoporosis is another thing that you see oftentimes as a non-pulmonary manifestation for these particular patients. And then pulmonary manifestations, they tend to have very frequent respiratory infections, which makes sense because if you have a lot of sputum production and it's thick, it does not allow for good airway expansion. And with the chest congestion, it just kind of sets up the perfect environment for frequent infections. They do have limited exercise tolerance. They tend to use a lot of those accessory muscles. When you think back when I talked about the assessment piece, you may see them showing some retractions. You may see them really sucking in around the diaphragm area, trying to get their breath. On pulmonary function tests, you'll see a lot of decreased function in them, as well as changes in the chest x-ray with increased anterior posterior diameters. So some of the non-surgical management revolves around this nutritional management, preventative maintenance therapy, as well as exacerbation therapies. So nutritionally, we want to, of course, monitor their weight, try to maintain the weight as much as possible. They typically will have some kind of supplementation in the vitamins. They may also have diabetic management, as well as pancreatic enzymes need to be replaced to help with digestion, to help with the management of the nutritional status. Preventative and maintenance therapy, they'll do some chest physiotherapy. This may include using like a chest physiotherapy vest that they put on that kind of rattles and rumbles them to help loosen up those secretions so they can be coughed out. They may do like positive expiratory pressure, different breathing techniques, activity or exercise, as well as gene therapy if they have a mutated gene present and they know that. Once the patient has an exacerbation, some of the main things you want to do is you may have to supplement them with oxygen. You may even have to do this heliox therapy, which is using like a 50% oxygen, 50% helium mixture to help improve that gas exchange and increase the oxygen saturation. They will do some airway clearance techniques. This is usually done with the respiratory therapy management of that. They may do things like bronchodilators, some kind of mucolytic therapies. They may do steroids if they need to. They may also put them on antibiotics to make sure that there's no infection going on. The one thing that we truly want to do is do everything we can to avoid mechanical ventilation, and that may include doing something like BiPAP on them to help open up those airways. That's that positive pressure stuff to keep those airways open. And then just really teaching them about good hygiene and pulmonary hygiene type things to prevent exacerbations from occurring. Because this is just a process that unfortunately patients with cystic fibrosis go through, where they have exacerbations, and then we have to try to get them better and then put them back on the preventative. And eventually what happens is they have an exacerbation that is just too bad. Those lungs just get too weak and can't take anymore. And eventually the patient then expires from the disease process. All right, and then we're going to talk about Burkholderia cepacia. I think that's how you say that. This is a serious bacterial infection that is found in patients who have cystic fibrosis. And the bad thing about this is it is resistant to antibiotic therapy. It is spread through casual contact from one CF patient to another. When they have these patients in the hospital, they tend to keep them in separate units than you would from other patients being hospitalized from CF. Because you don't want them contracting it. And this only affects patients with cystic fibrosis. So they will put them in different units. If the patients have had or have this particular organism and are coming to the physician's office, for instance, they will schedule patients on different days. So they'll have the patients who are sick with this infection come in one day, and then they will have the patients that don't have it come in on a separate day. And in the meantime, they will do a good thorough cleaning of the facility before the patients come in to be seen, those that do not have this particular infection. They do try to treat it with Bactrim or Septra, along with other medications that are used in the exacerbation, like some of those steroids and things like that. So basically teaching the patient to protect themselves by just good hygiene practices, washing your hands, covering your mouth when you cough, all those kinds of things is a good practice to get in the habit of. This is found on page 583 in your Iggy book. It's not very long, it's just a couple paragraphs, but interesting to read and good knowledge, because I have actually seen NCLEX questions about this very topic as it deals to cystic fibrosis patients. And now to look at the surgical management of cystic fibrosis, which I don't know that most people stop and think about surgical management of a disease like that. But basically, it's just simply transplanting different organs that have failed in that particular patient. So the patient may be a candidate for a lung transplant or even a pancreatic transplant if that organ becomes severely clogged and diseased. It does not cure the patient from the disease process. They still have the issue with the transport problem with the chloride, but it does extend their life by about 10 to 20 years. Their rejection rate, unfortunately, is very, very high. They are at risk for lethal pulmonary infections still. And probably priority-wise for nursing, you want to teach them about good pulmonary hygiene, as well as learning how to assist the patient in like strengthening those muscles and conditioning them. Your book does a really good job talking about surgical management on page 583 and 584, where it actually talks about preoperative care as well as the actual operative procedures, and also postoperative care, getting, how do you teach the patient and what they need to know about following the actual procedure itself. Corticosteroids are avoided for the first 10 to 14 days because of the effects on wound healing. So they won't use those initially. So keep in mind, we talked about some of the medications used in exacerbation. One of those things are steroids, and so they won't be able to use those in the first 10 to 14 days because the wound healing will not occur that they need to have happen. So pulmonary arterial hypertension, and you can find this in your Iggy book on page 584 and 585. It's basically a disease process that occurs in the lungs due to usually like a thickening of the pulmonary arteries that causes like resistance to them actually being able to open up. So it puts a lot of pressure or squeezing down and causes hypertension within the pulmonary system itself. They suggest, or they say that perhaps up to 50% of patients with pulmonary arterial hypertension probably have some kind of a gene mutation that just codes those receptors, so they can't activate and allow for affecting that smooth muscle in the lung itself. Even though patients may have the mutation, it doesn't mean that they'll actually develop pulmonary arterial hypertension. It can be related to some kind of disease within the lungs themselves. It can also be related to heart disease, which kind of makes sense if you think about it. You get a lot of pressure in the heart pushing back on the lungs. It causes pressure in there as well. But primary pulmonary arterial hypertension usually occurs in the absence of other lung disorders, or maybe also referred to as idiopathic pulmonary hypertension. But one of the things that they say may cause this is some medications. Several years ago, there was medication called fen-phen, which was used by a lot of people to lose weight. And then unfortunately, patients wound up developing pulmonary hypertension while they were taking this medication. And a lot of them were younger women. I actually took care of a patient several years ago here in Miami. So it's probably been close to 20 plus years ago with this very thing, with pulmonary arterial hypertension that was caused from fen-phen. Like I say, it basically results from blood vessel constriction with increased vascular resistance within the lungs themselves. This leads to poor exchange of gases, and so the patient winds up with hypoxemia or becomes hypoxic. It also can lead to right-sided heart failure. And without treatment, the patients will die within 2 years of this process. Again, the Khan Academy has a really great video that actually, helps understand the patho again of this, as well as how the medications and how they work and affect all the different receptor sites. So if you need additional resources, because there's not a lot in your book, that would be a good place to go. So the pharmacological interventions, these patients are typically placed on warfarin, and this is just used since we've got decreased perfusion going on to make sure that there are no clot formations. They may also use calcium channel blockers, as these are used to help dilate blood vessels and open them up. We may use these endothelin receptor antagonists as well as the prostacyclin agents. And these, I hope I'm going to butcher this word, guanylate cyclase stimulators, and that endothelin receptor agonist, the prostacyclins, and the guanylate cyclase stimulators are the three that are the best used for this particular disease process. They may also use digoxin to help the heart to beat more effectively. They may put them on diuretics to decrease the load, as well as these patients may require some oxygen therapy. Your book does a pretty good job talking about all these on page 585, so probably wouldn't hurt to kind of look those over. There is a little action alert box on page 585 as it relates to the prostacyclin agents, using them IV. So something to kind of note, usually when they have these little action alerts, it's because that's something NCLEX would like to test you over, so I would look at that. So acute respiratory failure, and this is ARF or ARF, can be found in your EG book on 624 to 626, and in your ATI book as well from 153 to 157. Acute respiratory itself can either be caused from a ventilatory type failure, some kind of oxygenation failure, or it can be a combination of both ventilatory and oxygenation failure. But regardless, it's typically classified by abnormal blood gas values, and the critical values to actually qualify somebody to be in acute respiratory failure would be a PaO2 of less than 60 millimeters of mercury, and SaO2 below 90%, or they could have a PaCO2 greater than 50 and a pH, or that pH less than 7.3. So it's pretty obvious to see that the patient is in some kind of respiratory acidosis state. The one thing that you will always see in a patient who's in acute respiratory failure is that they are hypoxemic. So they have that low arterial blood oxygen level going on. Right here is just looking at some of the reasons you can have a patient in acute respiratory failure, whether it's a ventilatory problem or it's an oxygenation problem. And you can see that sometimes it can be involvement of the chest wall, problems with the wall itself, a defect in that respiratory control center in the brain, which your respiratory control center is your medulla oblongata as well as your pons. You may have poor functioning of the respiratory muscles themselves, especially of the diaphragm. And this always makes me think of my mother-in-law, who did go into acute respiratory failure, and she had a partially paralyzed diaphragm, so she had poor function of that particular muscle. It could be extrapulmonary causes from some kind of neuromuscular disorder, something like a spinal cord injury. Maybe they've had a stroke, maybe they've got meningitis, they've got some kind of disorder going on that's made them have increased intracranial pressures, or it could be the use of like opioids. Some of the intra or within the pulmonary system itself, airway disease, things like COPD, maybe they've got a PE. There is a table in IGGI, or there still is, and I didn't change the page number on this, I just saw that. It is on page 625. Some of the oxygenation failures are just insufficient oxygenation at the pulmonary level, down in the alveolar area. Ventilations are normal, but your lung perfusion is decreased. You may have some shunting of the blood. You may have ventilation, perfusion mismatches going on, things like ARDS. Abnormal hemoglobin. If you don't have enough of those oxygen carrying capacity, it's not going to get oxygenated. And again, this is going to be on page 625, which is table 32.3, that looks at some of the common factors responsible for oxygenation in acute respiratory failure. You can also have a combination of the ventilatory and oxygenation failures, and this is what you typically see in patients who have abnormal lungs for things like chronic bronchitis, emphysema. They have frequent asthma attacks or have cystic fibrosis. And then it just talks about, the diseased bronchioles and alveoli cause the oxygenation failure, the work of breathing increases, and the muscles themselves are unable to effectively function in the patient with a combined failure problem in respiratory failure. And again, your book does talk about the combined, if you're a little more interested on exactly what's going on from the patho side of that. Okay, and some of the interventions that we'll see used for acute respiratory failure, of course, is oxygen therapy. And you're going to use the appropriate oxygen delivery system according to what the patient's needs will be. If you are unable to correct the hypoxemia with just, oxygen therapy, whether it be through a mask, nasal cannula, you're probably going to have to consider the possibility that you're going to have to actually get this patient prepared for mechanical ventilation and intubation. So that's where down at the bottom we talk about some of the neuromuscular blocking agents such as propofol that you'll use on these patients if you're going to have to mechanically ventilate them. Aside from the oxygen therapy, you want to position them for comfort, and for most patients that are short of breath, they're going to want to be in a more of a high Fowler's type position, or in a Fowler's position. They're not going to want to lay flat, and it kind of makes sense too. If you think about breathing, when you put a patient up high, you're actually using gravity to help work the diaphragm. It's not having to work against gravity when they're in that sitting position as opposed to a reclining position. So you're going to position them for comfort. You're going to help them to relax. You're going to do diversion, guided imagery, something to help them kind of calm down because, if you're short of breath, you're very anxious. Some energy conserving measures, you're going to try that as well. Some of the medications, you may look at meter dose inhalers, some of the corticosteroids, some analgesics. You may actually have to give them some kind of benzodiazepine to help relax them. And then again, if you have to mechanically ventilate them, you're going to have to prepare them for intubation. And so you're going to give them some medications that just kind of help relax them, put them out so they're not fighting the ET tube and the ventilator. So we're moving right along with our respiratory disease processes here. The next one we're going to talk about is acute respiratory distress syndrome, or you may hear the term ARDS, ARDS, and this is found in your book on 626 through 628, as well as in your ATI book from 153 to 157. And basically, this is kind of a real quick little rundown of the pathophysiology. Kind of describes what's going on within the lungs. So typically what you see is there will be like a systemic inflammatory response that winds up injuring that alveolar capillary membrane. When it does that, it makes it more permeable to the larger molecules, which then fills the space with fluid. And there's also a reduction in their surfactant, which if you think back to, your A and P class surfactant is kind of the oil, shall you say, in the lungs that help keep everything so that it opens and expands without resistance. So you'll have a reduction in that, which weakens the alveoli itself, which then causes them to collapse or either fill with fluid. And this all leads to a worsening of edema within the lungs, which ultimately then hinders the ability of the lungs to do their job with gas exchange. So they're not oxygenating and they're not able to pull off that CO2. So what can you expect to see in your patients who have acute respiratory distress syndrome or ARDS? Some of the key features are things like persistent hypoxia, and this is regardless of your efforts to try to give oxygen therapy, you're just not able to pull them out of the hypoxia. You have decreased pulmonary compliance, which if you think back to the previous slide, that makes sense because I've already told you that we're having issues with the alveoli, we're having issues with the surfactant, and so they're not able to open and expand those lungs and they're filling with fluid. Again, no brainer here. If they're doing all these things and they're hypoxic, they're going to have dyspnea. This is non-chronic associated bilateral pulmonary edema on chest x-ray, which the next one kind of deals with that dense pulmonary infiltrate seen on x-ray. And this particular disease process often occurs after an injury to the lung of some kind, whether it be from sepsis, the patient's had a burn injury, this could be any kind of burn injury, but I'm thinking especially of like an inhalation burn, pancreatitis, any kind of trauma, and transfusions. Within 6 hours of a transfusion, you may see this occur. The sad thing is once somebody goes into acute respiratory distress syndrome, they have a 60% mortality rate with this particular process. So this is never something that we want to see in our patients, and very important that we recognize it quickly so that we can get the intervention started as soon as possible to give our patients the best chance of living. Diagnostically wise, when we're doing our assessment, you're going to see a lower PaO2 value on the ABG, which again, think back, I just told you that they're having trouble with hypoxia or hypoxemia, where they're not able to get enough oxygen concentration, so it only makes sense that that's going to be low on your ABG. They're going to have refractory hypoxemia or I get this word out, hypoxemia. Which basically means no matter what you're doing, like I kind of mentioned on the previous slide, they can be on 100% oxygen and you are not able to bring that saturation up. They're just not able to compensate for what's going on in their lungs, no matter what we're doing with oxygen therapy. If you do a chest x-ray on these, we talked about the infiltrates on the previous slide, they will have a whited out appearance, or you may see the radiologist call it a ground glass appearance on chest x-ray. That is something that is indicative of ARDS. There is no cardiac involvement, so if we do an EKG or an ECG, we're going to see that the heart is not causing the problem, because you kind of think about there's a lot of edema. You want to rule out heart failure and those kinds of things, but you'll see that there's no cardiac involvement with these particular patients. And then if you're doing hemodynamic monitoring, which we're going to talk about next week in our critical care skills lab, you will see a low to normal pulmonary capillary wedge pressure reading on these particular patients. And then I've written in here that your book does have some good assessment findings that you probably need to look over and review on page 627 that just kind of talks about some of the other things that you may see. So once we have the diagnosis of ARDS, what do we need to do to help these patients? They will be intubated. Like I said, they cannot maintain their SaO2 on their own. So these patients are intubated. They're placed on a ventilation. I said ventilation, should be a ventilator or mechanical ventilation with positive end expiratory pressure or CPAP. Some of the drugs and fluids that they may use antibiotics, they may give them vitamins, they may give them this N-acetylcysteine, if I get it out of my mouth, nitric acid oxide, as well as some surfactant replacements, trying to help with the compliance to get those lungs to be able to open up. You want to be conservative on your fluid therapy, monitoring your patient. Keep in mind that they're filling up, so you don't want to overload them on top of everything else, but they're definitely not able to hydrate themselves, so you're going to be doing some conservative fluid therapy with them there. Nutritionally, since they're not able to eat, they may need to have enteral or parenteral nutrition given to them as soon as possible to help them fight. Case management typically gets involved, and this is divided into 3 different phases. If you look on page 627, I believe it talks about your 3 different phases that they go through. Let's see. Okay. So once we have our diagnosis of acute respiratory distress syndrome or ARDS, we're going to have to figure out what we're going to do with our patients from the intervention standpoint. These patients do get tubed. They do get an intubation tube so that they receive mechanical ventilation with positive end expiratory pressure or PEEP, or they may do continuous positive airway pressure, or that CPAP. Drug therapies, they may be given some vitamin C, vitamin E, antibiotics, this N-acetylcysteine and nitric oxide, as well as surfactant replacement, because keep in mind the surfactant has been decreased in this process, so this just helps with compliance of those airways. They're going to be managed for fluid replacement, but you need to be fairly conservative because we've already discussed that their lungs are filling with fluid due to some of the other processes going on. So you don't want them dehydrated, but you don't want to overload them as well. So you're keeping a good constant eye on the fluid status of your patient. Nutrition-wise, they're probably going to need to have some enteral feedings or parenteral nutrition given to them as soon as possible to help their body just stay, I don't want to say healthy, but just good nutrition going on, because the cells themselves can't heal if there's not proper nutrition. So we're just adding injury to insult when we're doing that by not helping them with their nutritional status. Case management is divided into 3 different phases, and these can be found in your IGI book on page 627. The first phase is the exudative stage, and this includes the early changes of the shortness of breath, the rapid heart, the rapid breathing, and this is where the alveoli become fluid filled, which makes sense. If you got exudate, that's what's going on in there. Some of your earliest interventions are just supporting the patient by providing oxygen to them. And then we have the fibroproliferative phase, where you see an increase in the injury itself to the lung that leads to the pulmonary hypertension and the fibrosis that occurs. The body does attempt to repair this to help reduce the issues with the gas exchange and the oxygenation, and also multiple organ dysfunction syndrome or MODS can occur at this point. Your interventions here focus on adequate oxygenation, preventing complications, and supporting the lungs. And then we have the resolution phase. This is usually going to occur after 14 days. It's the resolution itself of the injury. And if the patient doesn't die or have chronic disease, okay, and fibrosis may or may not occur, and the patients surviving often have some kind of neuropsychological deficits afterwards, because you have to think about this, they've been, deprived of oxygen no matter how hard we're trying to get that oxygen saturation up. So they've probably suffered an injury from that. One thing that I forgot to mention on the previous slide, talking about the acute respiratory distress syndrome or the ARDS, is these patients usually, as it progresses, they do better if position-wise they are in a prone position. And so you may see them placed on a roto-prone bed, which helps to turn them. So you're not having to, physically do it, which causes distress to the patient. The bed will actually do it for you. So some of the things with like a rotoprone bed is, and I've got orders here from Freeman that I'm kind of looking at, but this is pretty standard across the board, is that they will need a central line and an arterial line prior to being put on this bed placement, just so we can be doing that hemodynamic monitoring. We have good access, so medications and things like that can be provided to them. You also want to be very, mindful of skin, the fact that they're laying face down, and so you may have to do things like put Mepilex to the forehead, their cheeks, their chin, any bony prominences, when they're being flipped over, where there may be pressure points. You want to maybe do some moisture barriers. You're going to do some protection of the eyes by putting something in there to keep the eyes nice and moist. And so there's just a little more care that goes into taking care of somebody when they're on one of these rotoprone beds. The recommendation also is that you want to keep that MAP above 60, or that mean arterial pressure. You're going to be watching their heart rate. You want them to stay in a good window. If it goes below 50 or higher than 140, you probably need to be notifying your physician. Same thing if that MAP drops below 60, or if you start seeing their respirations increasing to over 30, and they have a change in their O2 saturation below 85. Those are all indications that the patient is going to need to have the physician called to have something else done, because the patient's not doing well at that point. And this is if they get unstable, these parameters, I should have told you that. If the patient becomes unstable and you return them to the supine position, you need to notify the physician if any of those parameters fall in those areas that I told you. So now we're going to move on to tension pneumothorax, and this again is in your EE book as well as your ATI book. This is a rapidly developing and life-threatening complication of some kind of blunt force trauma. Okay, it results from an air leak in the lung or chest wall, and basically what happens is the lung then collapses because it loses its air. Says here, because the trapped air cannot escape, pressure can compress the blood vessels and limit blood return. So you can see why this is an emergency situation. This process itself leads to decreased filling of the heart and reduces cardiac output. So not only are they unable to oxygenate because they have one lung that's deflated, now you have all the air escaping into the chest cavity, which is then putting pressure on the heart, so the heart cannot effectively pump. And this is one of these things that if you do not treat this promptly or detect it, this can lead to death of your patient. So this can be a fatal situation. So what do you look for as the nurse? Of course, your patient is going to be extremely short of breath and in extreme respiratory distress. You do look for asymmetry of the thorax. So you look at the actual wall movement itself. Does the chest expand and fall equally on both sides? When you look at the trachea, you will see movement away from midline towards that unaffected side. So the pressure, for instance, if I had a right lung that went down, the pressure from that right side is going to shift that trachea over to the left. And if you ever watch trauma shows, that's something that they'll talk about. You hear them say trachea is midline. That's one of the reasons they do that. They're assessing for these kinds of problems. You're not going to hear breath sounds on that side, which makes sense, because if the lung is collapsed, it's not opening and expanding, and you're not going to be able to hear the breath sounds. You're going to see distended neck veins, and of course that's going to happen because you've got pressure within the heart itself, which is not allowing it to fill and pump, so you're going to have backflow. It's like putting a tourniquet in the chest. They're going to become cyanotic. Hypertympanic sounds upon percussion, because now you have air trapped in the chest cavity, and with percussion it's very kind of a higher tympanic sound when you're feeling it on your finger as opposed to going over a solid surface. And then they will also be very unstable hemodynamically. And this is just for those of you who are visual like me, kind of gives you a good picture. So you can see the actual illustration there on the left that shows where the lung has collapsed, that air has pushed out, and you can see it actually on the x-ray too. That big black blob is all air that is now trapped within the chest cavity. And so this is putting pressure now on the heart. And so this patient is in trouble if we don't do something really quickly to help them. Okay, so what are we going to do for them? Well, the initial treatment is immediate needle thoracostomy. And what this is they're going to take a very large bore needle, they're going to insert it into the space of the midclavicular line of the affected side, and they're going to actually drain out the air. So you kind of hear that sound coming out the needle. Then they're going to also place a chest tube on this affected side so that it is allowing that chest to decompress and that lung can then re-expand. I did put on here, and this is something you probably need to look over because keep in mind you're going to have critical care skills on this exam as well. So that will be things like chest tubes, ventilator management. So in your book on page 590 through 592, it talks about chest tube care, especially chart 3012. Has got some good information in there. And then we're also going to look at managing their pain control because this is not a pleasant experience to have occur. And then we're also going to do good pulmonary hygiene to make sure that the patient stays healthy or does not have further complications like the development of pneumonia or something like that down in that lung because it's not expanded. Okay, so our last topic for this particular lecture is going to be pulmonary embolism, or a PE. You can see on illustration, the picture over here on the left shows where the pulmonary embolism is. And then basically, I think of this as almost like a stroke in the lung, just like in the brain where the blood is clotted off from some kind of event and cannot get perfused. The tissue starts to have issues, and the same thing happens here. In the lung, only it's lung tissue that's being affected. The picture on the right, this was actually given to me by a student. It's rather scary when you look at it that this was actually an embolus that was pulled out of somebody. That is the biggest thing I have ever seen in my life. And I think to myself, this had to be something that just over time just kept forming and forming and forming and forming. The patient probably had problems, but it wasn't until, the end that they finally had the big event, shall we say. So a PE itself, this occurs from some kind of substance entering your venous circulation, and it forms blockages in your pulmonary vasculature. Typically, it comes from like a DVT somewhere lower, like maybe down in the leg. That's the most common cause, where part of that breaks off, floats up through the vasculature, goes through the heart, and then gets pumped into the lungs, and then causes this infarct to occur. But it can also be caused from, tumors, bone marrows, amniotic fluid. It can be caused from air being pushed into a line. That's why we make sure our lines are clamped when we've got central lines. We don't leave them open. And what will happen is the patient does become hypoxemic and eventually loses function to that lung. This is considered a medical emergency and needs rapid recognition and treatment if the patient is to survive this event. So who's at risk? Of course, people who have prolonged immobilization, it's just kind of setting them up for formation of DVT. So sometimes what we see is people have been recently traveling, whether it be in a car for a long period of time or long plane rides, and then they get somewhere and then they start having issues with pulmonary embolism. This actually happened to a friend of mine who went to France. Once she got to France, she started having a lot of respiratory distress, went to the hospital, and they actually discovered several small pulmonary emboli in her lungs that originated from a leg because she had actually broken her leg prior to that, and then she took this trip. So it just kind of was the perfect storm for development of a PE. Central venous catheters can also be a source or a risk factor. Number one, because they can get a fibrin sheath on the tip of that catheter, which can break off and get pushed through the vasculature and lodge in the lung itself. Or like I mentioned before, if somebody leaves that line open, air can go in and the patient can then develop an air embolism, which causes this PE. Surgery, being obese, again, because it affects circulation. Advancing age, again, think about that. Everything kind of starts to slow down. The longer you live, the more you have opportunities to form plaque formations that can eventually break off and go to the lung. Any kind of condition that increases blood clotting, so a patient who, for instance, has like thrombocytosis, or hemochromatosis, where the blood is really thick, something like that, they have a higher risk of developing pulmonary embolism. And then just a history itself of having thromboembolism, like if we know somebody has a DVT in their leg or had multiple DVTs that have had to be treated, these people would be at a higher risk for development of pulmonary embolism. So some health promotion and illness prevention. We know smoking cessation will help, reducing weight, increasing physical activity. If you are going to have to travel for long periods of time, it's important that you stop, frequently get out, walk around if you can. If you're on a plane, you may just need to get up and walk back and forth down the little walkway there. If you have some kind of DVT, we're not going to massage or compress the legs. Don't want to do anything that breaks off a clot and send it to the lung. So how do you recognize a pulmonary embolism, or what are your clinical manifestations that you would expect to see in these patients? Usually they're going to have like a sudden onset of shortness of breath or dyspnea. They're probably going to get tachycardic. They're going to get tachypneic, where they're going to breathe fast. The heart rate's really going to be going. They may have a sign of apprehension or restlessness. They typically have some kind of sharp stabbing pain that hits them in the chest. They get this feeling of impending doom that kind of comes over them. They usually will cough. They may have some blood when they're coughing. When you listen to their lungs, you may hear some crackles or a pleural friction rub. You may also hear like an S3 or S4 heart sound, which is not normal. You normally just hear S1 and S2, so you might actually hear a 3 or a 4 in there. Remember Kentucky and Tennessee. They are probably going to become diaphoretic or get clammy and sweaty on you. They may develop a low-grade fever, and like it says down here, even like flu-like symptoms. And the petechiae itself usually sets up over the chest and the axilla area. I remember when I was in school, they kind of told us if you draw a line between the nipples and then kind of go up, that's where you're going to see that petechiae start to show up, and it's almost like they look purple on their skin tone. Their skin tone gets so many petechiae that they kind of look purple or blue in the upper chest area. So those are some of the things that you may see. I will say that your ATI book has a whole chapter 24, which is just a few pages long, is devoted to nothing but pulmonary embolism. And then you also have quite a few pages in your Iggy book, and there are some classical or clinical manifestations or key features of PE in your book on this chart 32.2 on page 618. Okay, so what kind of tests do you do if you suspect your patient is having a PE? Well, one of the things we do is we do ABGs, which makes sense if you think about it. If they're having a difficult time breathing, we want to know what their oxygen status is and their respiratory status. And one of the best ways we can do that is by ABG. And one of the things that we'll see is that this FiO2 ratios with the PO2 falls, and this results as a shunting of the blood from the right side of the heart to the left without picking up oxygen from the blood itself. So that's actually looking at your ABGs. You'll also see like the low PaO2, stuff like that on your patients. Even if you do ABG studies and your pulse oximeters show hypoxemia, that's not enough in itself to diagnose the patient with a pulmonary embolism, because sometimes, just like my friend who had multiple PEs, her SaO2 was never really affected that much. She knew she was short of breath, and she knew she was having some pain in her chest. So if there are small PEs, you may not actually see any change in that SaO2. They will do a CBC, a basic metabolic panel. They'll probably draw troponin and a BNP, which is used, BNP, we normally associate that with heart failure. They may also draw like a D-dimer or some kind of a fibrin split product test to look at they're looking at kind of like the coagulation status of the patient, and like that D dimer and that fibrin split time may be elevated. Again, that does not indicate itself that the patient has a PE, but it is, when you start putting all the pieces together, it's kind of leaning you more towards that diagnosis. The thing that is the gold standard is this pulmonary angiography, or they may do a computed tomography, pulmonary angiography, where they're actually looking at the vasculature itself in the lungs via testing in the radiation or in the radiology suite. And so that is our gold standard to actually be able to look in there and say, yes, I see a blockage in one of those vasculatures, and that is what's causing the problem now. Okay, the patient's been diagnosed with a PE, so what are we going to do to help them? Some of the non-surgical things that we do is oxygen therapy, and we'll use whatever appropriate delivery device for the patient to maintain the saturations that we're trying to attain. And we're going to be, of course, we're going to do that. We're going to do continuous monitoring of the patient's SpO2. We're going to be constantly assessing their respiratory and cardiac systems. We want to make sure that we have good, adequate access venous-wise, because we're going to be administering medications. They may need fluids as well as vasopressors if this is severe enough that they have a hypotensive type crisis where they need us to help maintain their blood pressures. They're probably going to be put on some kind of anticoagulation therapy to help the body get rid of this clot quicker and not, more importantly, not have any further development in that clot. On page 619 on this chart 32-3, it gives you the best practice for patient safety and quality care according to CUSIN, and it says care of the patient with pulmonary embolism. And so there's a long list. I'm not going to sit here and just read them to you, but I recommend that you look those over, as well as looking in your ATI book for interventions for your patients. And then some other non-surgical management is they may actually use some kind of fibrinolytic therapy. Kind of think of like your TPA, that kind of stuff. You're going to assess them for bleeding every 2 hours. So that means looking at their urine, there's still any kind of drainage that's coming out. You want to make sure that there's no blood in any of that. You're going to measure their abdominal girth every 8 hours. And that's to make sure that they don't have any internal bleeding. So if your abdomen is increasing, that's a good indication that you might have blood leaking out into your cavity. We're going to monitor their laboratory values. And I will say that on page 622 in this chart, it gives you a good idea of the things that they typically monitor, and these are looking at your anticoagulation type therapies and what they would monitor. And then on page 621, there's another chart that talks about the different drugs that they may use, from heparin. That's kind of back on the previous slide, all the way down to these fibrinolytic therapies, or that TPA, like we talked about in stroke management. So good information and a lot of quick little bursts. There's also a nice little table on page 620, 32-1 that talks about the severity and management options for patients with different levels of PE, whether they have a low risk PE, a submassive, or they have a massive PE. And so it just kind of tells you what you might see, what you're going to do to actually help them based upon the severity of the event. And then lastly, we look at surgical management here on this slide. And one thing they can do is an embolectomy, where they actually go in and retrieve the clot itself and pull it out. Or they may choose to put in a filter in the inferior vena cava, and this just helps if the patient, for instance, has got a history of having DVTs. They may have already had a pulmonary embolism in the past, and this has been an ongoing problem. They may choose to put one of these filters in to catch anything that breaks off in the lower extremities or down lower, so that it does not travel up to the lungs and create another PE. So that the filter itself is more of a preventative measure, but the embolectomy is actually going in and retrieving it to fix the problem. And the very last slide here, I feel like my lectures are never done. until I put something about Khan Academy on here because I just love this site. They do have some great presentations, and it is free. You just log in, and I think it's under Health and Medicine is the tab that you click, and then you can start looking up these other things. And so some of these are found under respiratory content, and then they're like the TB and influenza are found under like infectious. But they do a really good job talking about these different disease processes like I talked about earlier. I know for me with the cystic fibrosis, there was a great little few videos that talked about the disease process itself and how the medications worked. So highly recommend you watch this. There's also a really good one on pulmonary hypertension that helps explain it all, as well as the TB. So a lot of really good slides. They don't take a terrible amount of time as far as lengthwise to watch these, but great resources to just kind of help make the pieces fit together and have those concepts start to click in your brain.